different options that you may have that are not necessarily surgical, but at the same time may involve surgery. And I think those are really important considerations. So let's start. Just to add to what, and thank you for the wonderful introduction. I would say it's been a wonderful journey over the last almost 15 years now, being at San Antonio, and mostly because of our OR staff and our nurses. And that can't be reiterated over and over again. I can't say it enough. And that means a lot to me as a surgeon and somebody who takes care of people and relies on a lot of people around me. I can't do it alone, so thank you. But our conversation today is going to be about biologic treatment options. And it will start to push into some of the surgical realm, but part of this is really to consider the different things that we can do outside of surgery. And they are sometimes sensible, sometimes not so sensible. And that's where we're going to talk a little bit about that. Decision making, a little bit of the biology. We're not going to delve into the details of it. It doesn't make sense to do that in this forum. But at the same time, if anybody ever has any detailed questions, then we can get into it. But let's get started. Can I open up
Yes, you
my
can
PowerPoint?
definitely share your screen.
Okay. There we go. Is that coming up okay?
Perfect.
Awesome. Oh, just lost it.
On our side, you're still good.
And oh, there we go. Okay. There we go. So first of all, why are we having this event? Why are we talking about this? Number one reason is because musculoskeletal disease is one of the most prominent and preeminent issues amongst Americans and worldwide even. But this is one of the things that causes people to come to the physician, their primary care doc, or directly to us as orthopedic surgeons, or sometimes to the emergency department. Pain and dysfunction, nobody likes it. Trauma in the form of fracture, ankle breaks, clavicles, elbows, hands, big injuries, tibias, femurs, car accidents, those kinds of things end up in the emergency department. Overuse injuries, hiking, cycling, running, those kinds of things. And then, of course, my specialty is in sports medicine. Those are all part of it. But overuse injuries in sports, or even big ligamentous injuries, ACL ruptures, multiligamentous injuries in the knee, shoulder dislocations, patellar dislocations, and all the things that come with it. So those are all fun things for me to talk about. Not so much for my patients, but the other things that are challenging, obesity and aging, plague our country, our world, but our country especially. And it's a touchy subject, and those are things that we have to address as orthopedic surgeons and as patients have to acknowledge. If we just look at a simple economic burden statistic, almost $1 trillion every year is spent on musculoskeletal disease. And that might just be simple visits to a primary care physician, maybe to the emergency room, maybe surgeries or complex things when it comes to cancers and more concerning musculoskeletal issues. But what are the different forms of disease? Osteoarthritis, of course, chronic pain. Sometimes those are difficult to discern and figure out. And then also difficulties with activities of daily living. Simple tasks such as getting in and out of the shower, taking care of your mother, somebody who has a father who can't get in and out of bed safely. Those are real considerations. On top of that, we have our younger population who are really challenging themselves and their bodies and often have injuries. And so those require lots of detailed attention. And we have a whole gamut and a whole spectrum of patients from pediatric population to our aging population. And so not one treatment is appropriate for every single person or population. So let's explore some of the options. First thing I get when I'm in the office is, well, do I need surgery? Generally, not right away. That's just that should be generally the last thing we talk about. Other than for things that are emergent or urgent, like fractures or dislocations, ligamentous instabilities, cancers, infections, most musculoskeletal issues can be managed conservatively at the outset. They may also require surgical intervention at some point, but at the outset, we always want to try and address them conservatively. What are the first things we should consider? Time and avoiding things that aggravate it. I mean, it's pretty simple. Don't need me to tell you that. But sometimes I do get patients who come in and they haven't given it enough time or keep trying to push through their discomfort. What are the supportive management options? Of course, simple things like rest, ice, compression, elevation. We are always going to try that first. Things like Tylenol, that's okay. And unless you have real liver issues, generally Tylenol is pretty reasonable. Some people can tolerate oral anti-inflammatories like Aleve, Motrin, ibuprofen, that sort of thing. But those who have cardiac issues or blood pressure issues, they may not be good candidates for that. And savvy enough patients who can read through a quick pamphlet and look through exercises, they can do some of this stuff independently, stretch and follow or heed the advice of rest, ice, that sort of thing, and time down. Those who are a little bit less savvy would definitely benefit from conservative management options like physical therapy. And then, of course, it's an age-old conversation about not forgetting the use of a cane or crutches, scooter, or walker, just assistive devices. Those are really important to think about. But surgery isn't always the answer right away. Frequent question, cortisone. Okay, is this a biologic? Not at all. It is a hormone. It is a medication. It's a very potent anti-inflammatory that reduces inflammatory enzyme productions. And it also reduces collagen production, which is helpful in a longer term scenario and can be helpful in a short term scenario as well. But it generally is not something that can be used on a regular basis. It's not a pain medication by any means. It doesn't solve underlying pathology. It will not reverse the pathology. And I have patients who frequently ask me, well, is this going to just solve the problem? No. That's not the case. It's a great rescue, but it's not necessarily going to be a long-term management option. And it usually doesn't act right away. In fact, sometimes after a cortisone injection or even starting an oral anti-inflammatory, it can aggravate the symptoms for a few days or even a night. But it typically will take a couple of days, maybe 2 weeks before you notice any improvement. If after 2 weeks, I don't have a whole lot of confidence that a cortisone injection makes much of a difference. But used judiciously, I think it's helpful, but in a chronic setting, it can cause major problems. And we see crystalline deposition into the joints, into the soft tissues, especially when we ultimately open up joints and start the surgical process. And we see the consequences of the failures of cortisone. But it can also result in infection. and also local osteopenia, which is loss of bone density. It's not too common, but every now and then you can also see avascular necrosis secondary to steroid injection, but it's very rare. Again, great as an optional rescue, but not a management tool on the long-term basis. What are some of the different options? First of all, we have to recognize and acknowledge the challenges that you might have. And they may be associated with compromised bone tissue quality, previous trauma, progressive osteoarthritis, and also underlying medical conditions, especially diabetes, cardiac issues, autoimmune disorders. Those are probably the top three things that are on our minds as orthopedic surgeons when we're looking at different treatment options, especially when we start to think about biologics, surgery. When it comes to biologics, let's review a little bit about terminology. There's a lot of confusion amongst the community as well, or maybe not confusion, but poor communication amongst the community and even amongst physicians. What are the different things that we hear about on a regular basis? Platelet-rich plasma, PRP. It's probably been most discussed amongst athletes and in the professional basketball realm, even in the NFL, sometimes in Major League Baseball, and then of course my other sports that I enjoy, hockey, but not as often. But things like autologous stem cells, what does that mean? Embryonic stem cells, autografts, allografts, xenografts. So these are some of the different things that we're going to discuss, and we'll go over in detail. So what does autologous mean? It's a tissue or fluid product harvested from your own body and delivered back to your own body. That's autologous. It's your own tissue. Sometimes it requires some processing before you can receive it back. For example, when somebody who has a very concerning situation with anemia or doesn't want to have any type of whole blood products, if they need to have some type of blood transfusion, you can donate your own blood ahead of time, have it processed and ready to go in case you need it back. That's autologous tissue. Tendons, ligaments, skin grafts, they also qualify as autologous, meaning your own tissue that's donated to yourself. So you harvest it and you put it back into your own body. Minimal risk for rejection, but it's not a zero risk because there are still risks of infection. And especially when it comes to blood processing, there are still risks for rejection, even with your own blood. Next one, non-autologous. Those are tissue or fluid products that are harvested from another individual and implanted into your body. So again, it can be a cadaveric ligament or tendon. It can be donated blood from the blood bank. It can be a donated liver, donated heart. Some things can be irradiated and sterilized so that you don't have much of a risk of immunogenicity. Some things are very, very concerning, mostly the major live organs, the heart, the kidneys, the livers, and often you need immunosuppressants to manage that. But that's what non-autologous means. It's donated from somewhere else or from someone else. Okay, well, in orthopedics, outside of the realm of cortisone injections and lidocaine, numbing agents, and the conservative things, what are some things that we can do still that are conservative, that are non-surgical? We consider platelet-rich plasma. And just thinking about what that means, people mostly know that platelets have been used for a long period of time and have been harvested for the use of biological treatments, but not necessarily in orthopedics. Where were platelets originally used? To help with clotting. When you had low platelets, You started to ooze and you needed a platelet transfusion. Well, guess what? People donate blood, serum, plasma, and platelets on a regular basis. And they're very, very important in our hospitals to use on for very specific scenarios. But along the way, scientists have realized that in those platelets are also lots of other healing factors. And what are factors? Factors are generally enzymes, and enzymes are proteins that have specific functions that coordinate and also, along with hormones, uh, coordinate the actual healing process. And sometimes they will help with an inflammatory process, which is very important, but also with an anti-inflammatory process. It's not a new concept, but at the same time, these platelets have been recognized to help remodel injured tissues. And the details of which are harrowing. But what's the process of harvesting your own platelets? So my kids will tell you that this centrifuge right here, it's a very fun ride that I will never go on ever again. You don't want to see me after that one, but they love it. But in a similar light, basically you take your own blood, venous draw, and you actually centrifuge it and you spin it down. And when you do that, it fractionates out into different layers, as you can see on the bottom left, and then also a little bit on the right side. And it's in a little bit more detail down here, where you have the actual red blood cells, which are down at the bottom because they're heavier and they get out to the periphery in that spin. And then you have your platelet-rich plasma. You have also a buffy coat and the white cell layer, which isn't as clearly demonstrated on this side, but it is in this picture. But
Dr. Patel,
yep,
I'm so sorry to interrupt, but can you just kind of focus on just one section? Some people are saying it's a little bit choppy. So I think when you're moving around a little bit much, it kind of cuts in and out of the audio.
sure, of course.
Thank you.
If we look at this picture on the right side, you can see the three different layers. And at the bottom, you have the red blood cells. In the middle, you have the platelet-rich plasma. And then at the top, you have your serum, which is the platelet-poor plasma. The layer that we're looking to get when we're using platelet-rich plasma is in the middle, and it has sort of an amber color. And in that plasma are those platelets, and in turn, those platelets have all of these different enzymes. And each of these enzymes have a focused purpose to help with the healing process of injured tissue, whether it's bone, ligament, tendon, skin. So things like platelet-derived growth factor, transforming growth factor, platelet factor, epidermal growth factor, epithelial cell growth factor, insulin-like growth factor. All of these things harvest and draw in things like collagen remodeling, additional vascularity. These are important things for tissue remodeling. In addition, it provides the attraction for undifferentiated cells. And we'll get a little bit into that with the stem cell projects, but it provides flexibility for healing of various types of tissue, not just one specific one or another, but it also triggers controlled cell division into a local area where it's delivered by injection. And there's a type of cell called macrophages. And these cells actually clean up scar tissue and contaminants in our soft tissues. And it promotes macrophage activity. In addition, like I was mentioning, it promotes the capillary growth and revascularization, which is very important for providing nutrients to injured and healing tissues. And this picture down at the bottom is a microscopic image of collagen sort of kind of conglomerated and crumpled together. But when stretched out, this kind of collagen has a very tight structure. And when it's not organized in an injured tissue, it doesn't function properly and it's loose and unstable. And platelet rich plasma can help reorganize this type of tissue. Now, stem cells. Stem cells are very similar to platelet rich plasma treatment, but in the sense that you are focusing on targeting some of the most basic cells that we have in our body. And they are the most flexible cells. And under the right conditions, with the right type of stimulants, we're talking about different types of enzymes, they can be differentiated into a series of different types of cells. So if you take a look, there's 3 levels of cells, basic levels: the endodermic line, the mesodermic line, and the ectodermic line. And from the endodermic line comes lung tissue, GI tissues. From the mesodermic line comes heart muscle, musculoskeletal tissue, bone, skeletal muscle, and then also the red blood cell lines. From the ectodermic line, typically parts of the skin and nerves and neurons, so part of our brain tissue, that comes from the ectodermic line. Now, given the different types of enzymes that each of these cells are subjected to, will determine what type of cell line they go to. Now, that's a very challenging proposition, and it's very difficult to sort out. As of right now, stem cell treatment involves concentrating the totipotent or pluripotent embryonic stem cells and injecting them into a local area and hoping for the best, without very clear delineation of how each of those lines are going to develop. So they can be harvested from a handful of different places. The highest concentration is from the pelvis, but it can be harvested from the humerus, the tibia, the femur, and even from fatty tissue. But the whole goal is to try and get those cells to regenerate in a healing capacity, whether it's for cartilage, for bone, ligaments, etc. But they need to be delivered into an environment where the local factors can influence or guide their conversion into the useful tissues. And so if it's in the joint, you're looking to try and restore some of the cartilage function or structure. If it's around the joint, sometimes it's ligaments. Sometimes it's behind a joint or around a joint, again, for tendons, but also inside the bone itself. The collagen structure can be influenced. How are stem cells retrieved? It's not easy and it's not always comfortable. This is a picture of an iliac crest. So this is part of the pelvis, and it involves burrowing a needle down into the pelvis. It's not particularly pleasant, but at the same time, under local or regional anesthesia, or even general anesthesia, it can be done and then prepared and ultimately processed and then injected into a joint, for example. Embryonic stem cells, similar to adult stem cells, but in much higher concentrations. And these cells are the most basic cells, and they come available at basically within 3 to 5 days of gestation. And people will always ask, well, how do you get those cells? Do you take it from, a live individual? But no, not at all. These are generally derived from cells that are donated by somebody who's gone through in vitro fertilization and have extra eggs to donate that they would like to provide for this type of treatment. And the cell delivery involves the same decision and injection process as anything else, but just the isolation. initially. What are the challenges of biologics? It's very difficult to prove that this is better than placebo or any other form of injection treatments, only because the best type of studies are double-blinded and randomized. And generally, people will know whether or not they've been aspirated and have gone through an iliac crest procedure to harvest their stem cells or not. So it's very difficult to conduct these actual studies. And most studies are provided by industry. And those are what we call white studies. And as useful as they may be, they tend to be littered with bias. And so we have to be very careful about making decisions based on the literature that we see from them by industry. We want to always practice evidence-based medicine as best we can. Whenever we have anecdotal studies, we have to be careful. When we have less than double-blinded randomized studies, we have to be careful. And so those are important conversations to have. But at least when it comes to the majority of the biologic treatments, they're safe. Are they predictably effective? Not always. And many times they're empirical, meaning the only way to know if it's going to work is by trying it. And as long as we feel confident that they're not going to harm anybody, then of course we'll have that consideration and decision-making process. So of course, to whom do you listen? Your doctor, your mom, your friends, your neighbor? Well, it probably is a combination of everything. And I would like to support evidence-based medicine. And I'm very comfortable telling my patients that I think this is a reasonable option, but I don't know that I can predict whether or not it's going to make a difference. If I thought that it would not be helpful, I wouldn't let you do it. Those kinds of conversations are important. What's right for each individual? Biologic treatments, PRP, autologous stem cells, embryonic stem cells, they're not covered by insurances. And insurances don't cover it because number one, they're very expensive. Number two, there's no evidence-based medicine saying that it's significantly better or statistically significant with improvement compared to a placebo or other treatment options that they do cover, like cortisone injections. So when you visit with your orthopedic surgeon or any physician who's going to guide you on these treatments, be prepared to answer all these questions. Can you describe your pain? Do you have mechanical symptoms? What are your goals? What have you done to manage your injuries, your symptoms? And ultimately, it's you and the people who you trust to help you make important decisions that can come to a conclusion on how to help manage your scenario. And hopefully you'll use the guidelines of not only concerned, but experienced physicians who are willing to listen to you and describe all these different scenarios to help you make those decisions. But ultimately, you have to do what's right for you. Now that brings us to the surgical realm. So that's a whole other conversation, and maybe we'll have a lecture on that. But there are lots of biologics that can also be used in a surgical setting. Not only the things that we just discussed, but things like allografts and xenografts, which are tissues sterilized from animal models. And these are all very viable treatment options in the appropriate setting. But yeah, if you need to have these discussions, feel free to give me a call. That's my information, and I'm here to answer additional questions. But more than anything else, before we end and open it up to questions. We just got back from Death Valley, and my daughter asked me not to make any dad jokes, but my real question for you guys is, if you're lower than low, then give me a call and I'll help you know. Badwater Basin right there, if you haven't been there. Fantastic.
Wow, those are beautiful pictures. Can you please put up your contact again? That way people have the opportunity to write down your information and how to get in contact
Yeah,
with
for
you.
sure.
Thank you so much. That way it gives everyone the opportunity to write down the information that they need. This was so informative. I learned so much. This is fantastic. So I did have a question for you though. While we let everybody kind of gather their thoughts and kind of type in their questions, how would someone know when they should have this discussion with their physician?
It usually doesn't take very much. Usually it's pain, discomfort. When somebody starts to realize I'm really having a hard time with just my normal daily activities, or I'm really pushing my limits, and I actually had one specific injury. That's easy. The harder scenarios are when something creeps up on you. It's been bugging you for a week, 2 weeks, a month, 3 weeks. I get people who come in and they haven't said a word to anybody about it for 6 to 9 months, maybe even a year plus. So the time that it makes sense to actually speak up about it, number one, speak up around the people around you first. That makes the most sense. And if there's significant, obvious signs like swelling, mechanical symptoms, instability, whether it's in the knee, the ankle, the hips, the shoulders, you should say something. But aches and pains, yeah, for sure. Yeah, it's okay to sit on it for a little bit. We're all used to a little bit of that. But if it lingers more than, a few weeks, it's probably sensible to ask about it. And whether it's with your primary doc or coming to us as orthopedic surgeons directly, that's okay as well. And we have the resources to evaluate these things, whether it's through x-ray, just physical exam, or just a simple history.
Wow, those are all great points. A few questions did come in. Will I need to have multiple treatments to get good results?
So it depends on the type of treatments. I would say things like cortisone injections. Sometimes it does take a couple of injections, and I will do that in the more acute setting, in the appropriate setting. For PRP injections, platelet-rich plasma, I will do typically one injection a month, up to 3 months in a row. I won't do much more than that because most people will know if they plateau. If after the first injection they see significant relief, but they're not where they want to be, I'll offer a second. And the same thing after the second. But after the third, probably not going to make much more difference if they're still really having a difficult time. Or you give it a period of time afterward, maybe a 6-month lag period. But I'm not interested in trying to hammer people with the biologics, only if they're making significant progress. And it can also get very expensive very quickly in addition. Same thing with stem cell treatments. It can be very helpful early on, but there's a diminishing return after multiple injections. And so there's certainly no evidence or any literature that shows how many injections. So it has to be a discussion on what the actual progress is with each individual treatment and with each individual patient's level of comfort. But generally, 1, 2 to 3 injections, not much more than that.
Awesome. You did mention PRP. So when you're doing the PRP injections, will there need to be any time off for that?
I would say generally you want to take at least a week or two because remember the PRP injections for it to take effect, it takes on the order of days to weeks because the platelets themselves are releasing all of these enzymes, all the factors, and their enzymes, they take a fair amount of time. We're talking on the order of weeks, sometimes even a month plus, for them to take effect and start to work. So even though you want to, or my patients don't want to take time off, PRP injections are not a reasonable way to do, not a reasonable treatment to use and then expect to be uh, able to do their normal activity or level of activity the following week, even. So it wouldn't be a surprise if it took several weeks for that. And so I generally recommend a minimum of a week before they start some of the lower impact activities. And then once they really start to see the effects of it, then ramp up to their expected activity.
Great. Gail asked, have you ever had any success with any stem cell therapies?
Yes. So with the stem cell therapies, I would say probably the most impressive and effective treatments have been in conjunction with surgical treatments, particularly with cartilage reconstruction. So I would say it's in those scenarios that I've seen most improvement with the stem cell, as opposed to with significant osteoarthritis in the knee or the shoulder, um, which do often respond to the platelet-rich plasma therapies. But with stem cells, probably not as much with more advanced osteoarthritis.
So, Dr. Patel, you do PRP injections yourself?
I do. We do them in the office. The PRP injections, as well, they're considered autologous chondrocyte plasminogen, which is basically the precursor to the PRP, and effectively it is the concentration of the platelets and releasing the factors that are in the platelets.
So there's a question. Have you ever had an insurance company that would pay for PRP injections? Have you ever had that? Or is it pretty much
Yeah,
self-pay?
we'll always request, but at least in the last few years, I honestly cannot remember the last time. I think the only time was under certain workers' comp scenarios that we've seen it actually approved, but that was after probably significant attorney litigation, those kinds of things, which is not my part of my practice, but
Right. Are you prepared to give a ballpark of about how much it would cost a person to have PRP injections?
yeah, generally for each injection, whether it's in the knee or the shoulder, whatever it is, it's about $550 to $600. I don't know the exact number, but that's the ballpark. That's per injection.
Okay.
And roughly per injection, do you know like how many injections it's going to take? Is it just one injection in whether it's the knee or shoulder and then you go back again, or is it like several injections at one point?
Yeah, that's the hardest part to predict, and I
Oh.
wish I could. And that's the conversation I have with all of my patients is I'll do the one injection and then bring them back in a few weeks, see where they are, and if they're still struggling, then I'll open up the option for that second, if they're so inclined. But I would never push a multiple series of treatments by any means. I would want to see how much improvement I get.
Perfect.
And I would say the injections that, especially with PRP, the ones that I've seen that are the most responsive are around the elbow and in the knees and even in the shoulders for osteoarthritis. But some of the ones that I haven't seen a whole lot of efficacy are around the heel, Achilles tendon, which I've tried, and even in our literature, been shown to be less than predictable.
There was a question, will most orthopedic surgeons suggest the type of treatment if appropriate, or must a patient suggest it?
I would hope any orthopedic surgeon who is considering all the different treatment options would give it as an option if it made sense. I don't even bring it up when I don't think it makes sense.
So Martha asked that she understands that there is not a definite answer, but is there a ballpark number as to how many cortisone injections in the shoulder joint are too many?
That's again a great question, and generally, early on in my career, just by my training and just what I had seen, I was giving a fair number of cortisone injections and sometimes even on a repetitive basis. But with ultimately with more evidence-based medicine that has come out, it's been shown that either repetitive or multiple cortisone injections are detrimental and don't provide any long-term relief. It provides repetitive short-term relief with the consequence of some of the other concerning things that we have discussed with the local osteopenia. So there's no one specific number. I generally don't like to do more than a couple of cortisone injections in any one specific area before we start to consider surgical options or some of the other biologic treatments, viscosupplementation in some scenarios, which is not specifically a biologic treatment, but another option.
Fantastic. Does anybody else have any other questions right now that they would like to ask? Well, we do have a few more minutes left, but that was very interesting. Do you have any other questions that you can think of, Kathleen? Anything that you might feel we should address or have Dr. Patel address?
Well, I have a little wrist issue myself. How about any of these treatments to treat wrist ligament problems?
Right. So definitely, after looking through the details of what we're dealing with, of course, is it arthritic? Is this more of a tendon issue? Those are things that we're certainly going to want to delineate, and we'll sit down and I'll torture you a little bit, take a feel of it. But yeah, there are different options, and if this is more of an acute setting, over the last month or two, then maybe a cortisone injection might be appropriate. If it's more of a chronic scenario, then sure, absolutely, PRP injections can be considered. Stem cell injections, probably not right out the door, because I would try some of the more financially sensible and efficacious treatment options that we have a little bit more literature on, rather than the stem cells.
So have you ever done stem cells on the wrist?
I have not. No. And looking at the literature, it's again not convincing enough to warrant to say that it should be done rather than any other form of treatment first.
I think you kind of already went through this question from Brian, is would any of the costs of PRP be covered under a Medicare insurance plan? But in general, I think you had already said that no insurance plan.
Yeah, pretty much no insurance will cover it, and definitely not Medicare.
Okay. And is there, the main reason is because the literature behind it, or is there another reason why it may not be covered by insurance?
It's generally because there's not enough evidence-based medicine to be able to tip it one way or the other.
Right.
But there's also many other factors that I can't even explain. They don't make sense to me. Yet they would, quickly approve a total knee replacement before trying some of these other more conservative measures, which are a lot less expensive than a total joint replacement.
I completely agree. Kathleen.
A question, is PRP effective for SE and or, I don't know where the question is.
AC.
AC joint pain? Sorry, I came late. You may have already touched on these and I don't think you did. So the
Nope.
question is,
Yeah, specifically for the acromioclavicular joint, usually in that joint, depending on age group and activity level, that is a joint that is actually fairly responsive to 1 or 2 cortisone injections. So I readily will do that first, and if that doesn't help, then I would definitely consider PRP. But I would try cortisone and some of the modification activities that we talked about before first.
So another question is a ballpark range for stem cell injection.
For stem cell injections, now we're starting a completely different realm. That starts to get into depending on what kind of anesthesia each individual patient would prefer, because it is much, it can be painful because you're harvesting from the pelvis generally. And so it can be done under local anesthesia, but there's going to be significantly more pain, even with local anesthesia. It can be done under regional anesthesia, meaning sedation. It can also be done under general anesthesia. But when it's done under regional or general anesthesia, that has to be done in an operating room scenario. And so that adds to the cost of the anesthesiologist and all that. So just ballpark figure, just for a surgeon's fee, generally it's going to be about $2,500 because of, at a minimum, because of the actual equipment that we need to have, not only the centrifuge, but the bags and the preparation setup. It's a little bit different than PRP, which is a lot less expensive. But at the same time, if it's not covered by insurance, but depending on the surgery center or the arena where it's performed, whether it's in a surgeon's office or at the surgery center, there will be additional costs, and that's I don't even know.
yeah, that's
Probably
so
significantly more.
you're saying on top of your fee or surgeon's fee, then you'd have
Right.
the anesthesiologist and all that. So
Yeah,
think
and also
there's-
just being in an operating room environment to help with the anesthesia.
So there's a lot more factors into the stem cell injection fees.
That's for sure. PRP is readily done in the office. Some stem cells injections can be done for willing patients, but most generally prefer to do it in the operating room.
And then one more question for you. What can be done for a trigger finger?
Trigger fingers are also very readily injected with cortisone and can be managed on a short-term basis. But if after a couple of cortisone injections, if the trigger continues to propagate or get worse or continues to occur, then it just makes sense to address it from a surgical standpoint. I don't think that PRP or stem cells are going to solve that problem. It's a mechanical problem at that point.
I think this is more of a statement. This is a very long statement. This is from Laureen. In March 2020, after several injections, including cortisone, which began in January 2020, Dr. Patel injected PRP. After 2 weeks, the pain was gone and has not returned. I am playing golf 2 days a week and still not experiencing any pain. Thank you, Dr. Patel.
So wonderful to hear.
That's a wonderful testimony.
definitely.
Well, the time is 6:59, and that kind of concludes today's community lecture with Dr. Patel. Thank you all so much for joining us on this wonderful and educational event tonight. Thank you so much, Dr. Patel. We truly appreciate having
Thank
you
you,
with
Dr.
us.
Patel. It was wonderful.
And
Thank you for having me, and thank you for all of your guys' attention. And whenever you have questions, please don't hesitate. I'm happy to reach out.
Thank you so much. Thank you, everyone. Have a wonderful evening.